All right, so we're going to cover chapter 28, face and neck injuries. So we're going to kind of move this one here a little bit faster. We kind of covered up some face stuff as well in the last chapter for soft tissue. So this shouldn't be too much more in depth, and a lot of this should be review of anatomy. All right. So, all right. So introduction. So the face and neck are particularly vulnerable to injury because of the relatively unprotected position of the body. So soft tissue injuries, fractures are common and vary in severity. So we're going to get more in depth with this part here. But penetrating trauma to the neck can cause severe bleeding. An open injury may also allow air embolus to enter in the circulatory system, which can cause cardiac arrest. Did it change? All right. So, A&P. The head is divided into the following. You have the cranium, also referred to as the skull, which contains the brain. So the posterior portion of the cranium is called the occiput, right? Occiput being the occipital bone also covers the occipital lobe. The occipital lobe controls the vision center of your brain, right? So if you have blurry vision, you smack the back of your head, you probably have some damage to your occipital lobe, and you could have a fracture of the occipital bone or the occiput. Right, so each side of the cranium, the lateral portions are called temples or the temporal region. The bone underneath it would be the temporal lobe. Right. The forehead is called the frontal region, which then has the frontal bone. And which lobe would that be?
Frontal.
Frontal, right? Pretty simple stuff, right? Then we have our parietal as well. We'll talk more about later on too. The forehead, obviously frontal. The interior to the ear is called the temporal region, where you can feel a pulse of the superficial temporal artery. So here is our picture here. All right. These little lines that go through here like this, and there's one out back here, and there's one across here, and there's another one that goes right down the top like this. Those are called sutures, right? This is the nasal bone here. Underneath the nasal bone, it comes down a little bit farther for your nose. This is all going to be cartilage down here. This is your zygoma, right? Or your orbits, which go around the eye, right? Your maxilla is on top of or underneath the nose. Your mandible is down here. This right here is your zygomatic bone or your jaw. And then obviously we have C1, C2, 3, 4, 4, 5, 6 as it goes down. C1 is called your atlas. C2 is called the axis. And C3 is just called C3 and C4 and C4 and so forth going down. There are 6 major bones, as we talked about here, right? The orbit of the eye is composed of the lower edge of the frontal bone of the skull, the zygoma, maxilla, and the nasal bone, which protects the eye from injury, right? So you may see raccoon eyes if you have fractures of the orbits. Only the proximal third of the nose is formed by bone. The distal form is all remaining cartilage. The other 2/3 is a composed of cartilage. Right. Now looking at the back. So the exposed portion of the ear is comprised entirely of cartilage covered by skin. So the external visible part is called the pinna. The tragus is the small, rounded, fleshy bulge immediately anterior to the ear canal. So the tragus is located here. Right? If you were in critical care medicine, that would actually mean something. This is the occipital bone here. Frontal, temporal, parietal. And the 7th cervical vertebrae is down here. So 1, 2, 3, 4, 5, 6, 7. All right. So about 1 inch posterior to the external opening of the ear is the mastoid process, right? The mandible forms the jaw and the chin. So, right, we're talking about the temporomandibular joint, which is located here. Sorry, here, I mean. So when you get that clicking sound in your jaw, it usually comes from up in here as well, right? And this is also where lockjaw will also come into place as well with certain other diseases, which we'll talk about a little bit later. So the neck contains many important structures supported by the cervical spine. So the first 7 vertebrae in the column C1 through C7, remember that the C1 though is considered the atlas and the axis is C2. The spinal cord exists from the foramen magnum, which is the big hole. There's plenty, so foramen being a hole, magnum being the largest hole that's there, and lies within the spinal canal formed by the vertebrae. The upper part of the esophagus and the trachea lie in the midline in the neck, and the carotid arteries are found on either side of the trachea, along with the jugular veins and several other nerves, as we can see here. So important landmarks. The Adam's apple is located near the center of the neck, okay? And the other portions of the larynx is the carotid cartilage, right? So we have our thyroid cartilage, which is located here. And we have our cricoid cartilage located below. In between that is what they call the cricothyroid membrane. So for paramedics, that's where they're going to do a surgical cric. It's going to be right there, right? The carotid arteries lie here. These are your jugular veins here. They have internal, there's actually 2 sets. There's internal and external jugular. You just can't see the internal ones. These are your external, internals lie in here, right? You have your sternocleidomastoid muscle, which runs down through the neck this way and this way. Your trachea is located here. And your cricoid rings or cartilage rings go all the way around. In pediatrics, those are not completely formed yet. And I'll show you in the next slide. All right. And you have your cricoid cartilage.
Kevin?
Yeah, go ahead.
Question. So you said that the carotid arteries are further out, and the
Here.
The veins are in. The jugular veins are. So what you actually are feeling when you're palpating for a pulse, you're actually feeling that carotid, the arteries, right?
You're feeling the carotid artery, correct? Not the veins.
There's no, yeah, not the veins.
Correct. So when you feel a radial pulse, you feel that bounding. You feel the pulse, the pressure, the bounding or the beats, I should say.
Yeah.
That's your left ventricle contracting, squeezing. Yeah. Right? Because you feel that blood flow. The left ventricle is very powerful. So in an EKG strip, that big up and down thing looks like a QRS wave they talk about. That's your ventricle depolarizing, causing that squeeze, making that pulse beat that you can feel. Yeah. Right?
So the veins, the jugular veins would have less pressure.
Right.
We wouldn't feel
it. There's 2 of them. There's internal and external jugular. Right. And then over here, you have a subclavian that runs over here as well. It comes into the heart. Right. So you have your laryngeal prominence or the Adam's apple, which is here. Okay. This is a big part here. This big blue part is your thyroid cartilage. This is the membrane right here. This is where you would do a needle cric or a surgical cric with a scalpel for medics. So when they're cutting somebody, that's what they feel for. They feel the cricoid cartilage, the thyroid cartilage, and the cricothyroid membrane being in the middle. And this is your trachea, and these are the rings I'm talking about, these blue pieces here. In a pediatric, they don't completely encompass the trachea, which is why it's so much more pliable. So that's why you have to have padded underneath the shoulders, so that way the trachea stays open. With an adult, it's got cartilage rings that go all the way around, which makes it more of a solid structure. So the trachea below the larynx connects to the oropharynx and larynx with the main passages to the lungs. Okay. The sternocleidomastoid muscle originates from the mastoid process, allowing for movement of the head. Right. So going back to the other slide here. Right. Those are those big muscles that start from the mastoid. Right. So sternocleidomastoid. So sternal, right? mastoid being up top, the muscle that runs through. Right. So the eye is a globe-shaped, approximately 1 inch in diameter, located with a bony socket. That's that socket that you see in the skull called an orbit. Composed of adjacent bones of the face and skull, protects over 80% of the eyeball. All right. And here's a picture of the eyeball here. The pupil, the lenses, iris, the cornea, looking at the anterior compartment filled with aqueous humor, so that fluid inside. Now, we have veins and arteries going to the eye, and the optic nerve, which is one of your cranial nerves, by the way, is the optic nerve. And you have retina, sclera being the white part of the eye, right? So if you have a patient that's jaundice, this right here basically wraps all the way around the eye, though, it's just cut out, will turn yellow. You'll see that change in the sclera. And here's your retina here, right? Those are some of the major structures of the eye that you'll see. So the clear jelly-like fluid near the back of the eye is called vitreous humor, right? So in front of the lens is a fluid called aqueous humor, which can leak out in penetrating injuries, right? So you got to pay attention for that, right? As you can see here, right? So the conjunctiva is a membrane that covers the eye. What disease would be conjunctiva? What kind of conjunctivitis? Right? Conjunctivitis, right? Which is an inflammation of the conjunctiva, which is here, causing that very contagious, right, fluid that comes out of the eye that can cause anybody else to get it. That's why conjunctivitis. That's an inflammation of the conjunctiva. The lacrimal gland, these are your tearing glands up here, your tearing ducts. So one of the things you'll see, and what was talked about in toxins, was lacrimation. Lacrimation fits into the acronym sludge or sludgum, which would be indication of which type of toxin.
The anti-cholerogenic, or is it the
Oh.
cholerogenic? You're basically secreting from every orifice. So the
I'm writing it out for you.
Huh?
I'm writing it out for you.
Oh, organophosphate?
Organophosphate poisoning, right?
Yeah, but what does that come under? What's the
Sludge.
No, I thought
Organophosphate is organophosphate poisoning.
Okay.
You look for either dumbbells or sludgum or sludge.
Okay.
So salivation, lacrimation, urination, defecation, emesis, meiosis. So again, toxidromes, things you guys really need to remember. Right? So the lacrimal glands produce fluid to keep the eye moist. It's also when you start getting tearing as well. The white being the sclera. You have the nasolacrimal duct as well here that can also take in fluid. The conjunctiva here, iris pupil. Right? Iris being the color part of the eyes. People have blue, green, brown. That's going to be your iris, the change in color. Important to pay attention to the white, the sclera, okay? That's what you're going to see if it's yellow. Again, if you see it's yellow, then their patient's jaundice, which would indicate what?
Liver.
Liver disease. Yeah, liver disease of some sort. Hepatitis C, yeah. Well, the sclera is the white fibrous tissue that helps maintain the globular shape. So on the front of the eye, the sclera is replaced by a clear, transparent membrane called the cornea, right, which allows light to enter the eye. The iris is a circular muscle behind the cornea, okay? So the pupil is the opening to the center of the iris, which allows light to move to the back of the eye. Anoscoria, okay, and understand this, you need to understand what this means, is a condition in which a person is born with different size pupils, right? If we saw this on a patient, what would we think right off the bat?
Head injury.
Head
injury, stroke, right? TBI, something, right? Okay, but if they have a history of anoscoria, that's normal. So the lens lies behind the iris. So focus images on the retina and at the back of the globe. Tina, you're on with Newfield, right?
I am.
Okay. You know John Moulton, right?
No, I just joined. And their meetings are
When you meet him, look at his eyes.
okay.
He has anoscoria.
All right.
Yep. And he talks about it. He actually acts as a patient sometimes in testing scenarios and see if anybody will pick up on it.
Well, maybe I'll ask him if I can do an assessment on him for
Ask
my
him,
class.
say, what's anoscoria? Can you tell me? It'll show you. So the retina contains nerve endings. So respond to light by transmitting nerve impulses through the optic nerve. Okay, being one of the 12 cranial nerves, by the way, to the brain. So the retina is nourished by a layer of blood vessels called the choroid, right? So retinal detachment causes blindness. So if you hit hard enough and you have retinal detachment, patient won't be able to see. This can often lead to partial or complete obstruction of the upper airway. So injuries to the face, we talked about there. I don't know why I got ahead of myself. My goodness. So several factors may contribute, like eyeballs and airway.
Retinal detachment causes blindness and then leads to partial or complete obstruction of airway.
I don't know where I went with that. We're injuries to the face and neck now, not the eyes. We're past eyes. I don't know where I was going. I just had a moment. I think I need to be assessed.
I was right there with you.
I need a neuro assessment now. All right, so injuries to the face and neck. So maybe. I need sleep. That's pretty much what it is. Injuries to the face and neck can often lead to a partial or complete obstruction of the airway. Several factors may contribute, oh boy, to the obstruction as well. So blood clots in the upper airway, heavy facial bleeding, direct injuries to the nose and mouth, larynx, and the trachea are often sources of significant bleeding and a respiratory compromise. Right? Injuries may cause teeth or dentures to become dislodged in the throat. If a patient has dentures, take them out. Clear the airway. Take out the dentures.
Unless they are fitting properly.
If they're falling out, take them out.
Yeah. But if they're stuck in, leave them because you don't stick your fingers in there.
I would probably still pull them out because eventually they come dislodged. I've had so many times where they come out. Ugh. But per textbook, don't put your fingers in someone's mouth. All right. Several factors include swelling that accompanies direct and indirect injury to the soft tissues can also contribute to other airway obstructions. The airway may also be affected when the patient's head is turned to the side as well. So possible injuries to the brain or cervical spine may also interfere with normal respirations. All right, which I'm sure that Morgan went over with you guys on neuro assessment and neurology. So the face and neck are extremely vascular. You have a small little cut in the head and looks like there was a murder scene, right? Swelling in this area may also become more severe. You'll see that in this guy's face, right? When I'm looking at this, I'm thinking orbital fracture. You had a laceration here. What else am I also concerned with?
Head injury, I would assume.
You said head injury?
Yeah.
Like a bleed, like a subdural, epidural, or subarachnoid. Subarachnoid bleeds, you most likely see more CSF leak, but maybe a subdural or a or epidural bleed. Right. So again, questions I'd be asking this person here: are you on blood thinners? Do you take blood thinners? Mandible fractures are very common because of the prominence of where it's located. Second to only nasal fractures in frequency. The most of these structures are a result of vehicle collisions and assaults. All right. So signs of mandible fractures would include misalignment of teeth, numbness of the chin, and the inability to open the mouth. Maxillary fractures are usually found after blunt force high energy impacts. So the signs of maxillary fracture would include facial swelling, inability or instability of the facial bones, and a misalignment of the teeth. So fractured and avulsed teeth are common following facial trauma. Teeth fragments can also become airway obstructions and should be removed immediately. So as far as patient assessment, seeing size up, ABCs, standard precautions, if there's, because of blood and potential projectile blood as well, determine the number of patients and consider the need for additional assistance. We're going to assess the scene looking for indicators of mechanism of injury. A lot of this stuff is the same thing, as you've noticed, right? It's all the same, but then there's some slight differences in our assessment. All right, common MOIs for the face and neck injuries include motor vehicle collision, sports, falls, penetrating, and blunt trauma. So again, we're focused on identifying and managing life threats, XABCs, treat immediately, and where there's life-threatening external hemorrhage, it should be addressed before any kind of airway or bleeding. Look for the general impression, sick or not sick. Look for indicators of seriousness of the patient's condition. Injuries to the face and throat may also be very obvious, but also be hidden by collars or hats. So you have to expose, you got to look, right? Control blood loss with direct pressure. Consider the need for manual stabilization and responsiveness using the ABPU scale. We're going to assess airway and breathing, ensure clear patent airway. Patient unresponsive or has an altered level of consciousness, consider a properly sized oropharyngeal airway, OPA. If they have a gag reflex, remember, it comes out and go with the nasal, as long as you don't suspect any kind of nasal or fracture. Quickly assess for adequate breathing. Splinting or otherwise restricting chest wall motion is contraindicated. Circulation. Assess for pulse rate regularity and quality, rate, rhythm, quality. And significant bleeding is an immediate life threat, so we need to make sure we're treating that. Right. The transport decision, consider quickly transporting the patient with airway or breathing problems or with significant bleeding. Stabilization and maintenance of an airway and breathing, as well as control of bleeding, can be very difficult in patients with facial or neck injuries. Consider ALS if it's a long transport, and the patient with internal bleeding must be transported quickly for treatment by a physician. The signs of hypoperfusion imply the need for rapid transport. So if you see that inadequate state of tissue perfusion or hypoperfusion shock, we need to make sure we're getting into a hospital. The patient who has significant MOI but whose condition appears stable should be transported promptly. Remember that significant blow to the face or to the throat should increase your suspicion of a spinal or brain injury as well. So even if the patient has no signs of hypoperfusion or other life-threatening injuries, there is a possibility of eye injuries as well. So yeah, just make sure you're taking a look, do a full assessment, touch and palpate to see what hurts and what may be broken. Investigate the chief complaint by getting your medical history, be alert for injury-specific signs and symptoms, battle signs, raccoon eyes, right? Tracheal deviation, jugular vein distension, step-offs of the cervical spine, right? Misaligned teeth. Look for all those different things that are there and get your sample history and be aware of impertinent negatives, such as no pain or no loss of sensation, right? Physical examinations of multiple systems are likely to have been affected. Start with the assessment of the entire body, looking for your DCAT BTLS. Do not delay transport. And in a responsive patient, again, who has an isolated injury with a limited MOI, consider focusing your physical examination. So again, you don't have to do that full rapid head. I mean, it's very detailed head to toe. You can kind of focus on specifically that injury if there's nothing else that was noted on your rapid, right? Nothing really significant MOI. So ensure the controlled bleeding is maintained and note in the location of the injury itself. Inspect the open wound for any foreign matter and stabilize impaled objects. During the physical examination, use both your eyes and your hands. Remember, you have to be touchy-feely with your patients, professionally, please. If your patient is responsive, you should explain exactly what you are doing, okay? Let them know. I'm going to be pressing on your face, pressing on your nose, touching the back of your neck. Let them know what you're doing, because that way they don't have any surprises. It's like with a 12 lead. Ma'am, I'm going to lift your breast up with the back of my hand. Remember, lifting with the back of your hand is professional. Grabbing with your hand is unprofessional. It's called groping, which we can't do to a female in the back of the ambulance, or unwanted.
Yeah.
So, and assess all underlying systems. When evaluating the eyes, start with the outer aspects and work toward the pupils. Visual acuity is considered the vital sign of the eye. All right. So we're looking for discoloration, bleeding, redness, eye symmetry, and pupil size reaction to light. Right. Visual acuity is the vital sign. Remember that. So we're looking for that's an E.
Pearls.
R. Perla. Pupils equal, round, reactive, light accommodation. Perrla. Perla.
What's the accommodation mean?
Do they have the ability to follow commands? So looking at like an H pattern, so moving so you start here, you go over, up, down, over, up, down, middle. Okay, that's looking at accommodation. Make sure they can follow commands. And when we're looking for that, we look for something where the eyeballs do this. They go back and forth. What is that called? When you're going back and forth and the eyes start twitching, going back and forth. You see it a lot with intoxicated patients. Use with an N. And you're going to note this in your narratives. Okay. It's called nystagmus. We're looking for nystagmus of the eye. So vital signs, assess vital signs to obtain baselines so that way there you can observe any kind of changes. You must be concerned with visual bleeding and unseen bleeding inside the body cavities with facial and throat. Baseline information about respirations and pulses are very important in user monitoring devices. End title. Reassess by repeating the primary assessment. Continue reassessing the adequacy of airway, breathing, circulation. Recheck patient interventions. This is particularly important with patients with facial or neck injuries because of the ease in which the injuries can affect associated symptoms. The patient's condition should be reassessed every 5 minutes for this and provide a complete spinal mobilization and any patient with suspected spinal injury. You have to do that head-to-toe assessment with them. You have to actually assess the spine, especially cervical. So we're talking about the head and neck, right? The face and head, neck. And make sure we have CSM checks as well. Make sure you get that neuro assessment if there's head trauma. Maintain an open airway. Whenever you suspect significant bleeding, provide high flow O2 and control any significant visible bleeding. All right. So if the patient has signs of hypoperfusion, treat the patient aggressively for shock and provide rapid transport and do not delay transport of a seriously injured patient to complete non-life-saving treatments in the field. Do it in the back of the ambulance. Right. And then communicate and document. All right. So emergency medical care, as far as soft tissue, treat soft tissue injuries to the face and neck, the same as a soft tissue injury anywhere else in the body. XABCs. But avoid moving the neck in patients with suspected cervical spine injuries. So when you have a patient that has potential cervical injury and he's standing there, right? Don't walk up behind him and say, "Hey, sir," make them turn around.
Yeah.
Right. I've seen that happen so many times when they walk up to address themselves, right? Or approaching them from the side where they have to turn their neck. Right. Try to approach them face forward and say, "Please keep your neck still." Right. And try not to move. Have someone hold manual stabilization, apply a cervical collar, and bring the stretcher behind them and have them sit down. Now, can they walk? Absolutely. They can. Just have them not make sudden turns. Right. We don't do backboarding anymore because it actually causes more damage to the patient. We can use it as an extraction device only. Control bleeding, apply direct pressure with dry sterile dressing, roller gauze wrapped around the circumference of the head, and hold pressure to the dressing. Right. Please do not wrap dressing around someone's neck like really tight. That'd just be a bad thing. Right. You really can't explain that to the doctors. Please do not apply excessive pressure if there's a possibility of underlying skull fracture. The last thing we want to do is put more pressure onto the brain. All right. So when an injury exposes the brain, eye, or other structures, cover the exposed parts with a moist sterile dressing. Apply ice locally to injuries that do not break the skin. And for soft tissue injuries around the mouth, check for bleeding inside the mouth as well. So take your pen light and take a look inside. Physicians can sometimes graft a piece of a avulsed skin back to the appropriate position. So if you find a portion of a avulsed skin, wrap that in a sterile dressing, place it in the plastic bag, and keep them cool. Like put them on top of an ice pack.
You guys have ice in the ambulance?
We have ice packs. They usually last about 15 minutes. So if you have a long transport, you have to keep changing it out. But not many services carry a lot.
Yeah.
At Action, they used to carry 6, but I mean, since I've been gone, I don't know if they've changed it or not. If there is skin attached in a loose flap, place it back in the position that is close to normal as possible. So you put it back onto the skin. For eye injuries, they're common, particularly in sports, can produce lifelong complications, including blindness. Proper emergency treatment will minimize pain and may prevent a permanent loss of vision. So after an injury, pupil reaction or shape and eye movement are often disturbed. So abnormal pupil reactions sometimes are a sign of brain injury rather than an eye injury. So just kind of keep that kind of stuff in mind. Look for that perla. Right. So treatment starts with a thorough examination. Look for specific abnormalities or conditions that may suggest nature of injury. Right. So try to take care not to aggravate any other problems again. Okay. So just kind of look at the eye and try not to make anything more aggravated. There's foreign objects. So like the orbit protects the eye from penetrating of large objects, but small objects can still penetrate and produce severe irritation. So irrigation of a sterile saline solution will frequently flush away loose particles. So here's one thing you can utilize. They're utilizing a nasal cannula to flush the eyes, as you can see in this photo here. So what you do is this nasal cannula coming out, and here's your tubing, right? It comes up. What you do is you take a bag of saline. There's a bag of saline here, usually 1,000 bag. Run a drip set out of it. At the end of the drip set, you connect it into the tubing of the nasal cannula, and you put a blood pressure cuff or a pressure bag up here, and you pump it up, and it literally will drip through and come out both prongs of the eyes, here and here, and it'll flush them out. If you are going to flush one eye over the other, turn the patient with the affected eye aiming down. The last thing you want to do is take the affected eye on top and leak it into the other eye. All right. So always put the affected eye down. If you're flushing both out, lay them supine and allow the liquid to come down into the eye and flush out on both sides like this. All right. But a bag of saline is perfect. Don't use ringers. All right. They're more expensive bags. Normal saline is fine for this. Sodium chloride. Bag, 15 drop set, or a 10 drop set, or 20 drop set, whatever macro set you can find. Pressure bag it by using a BP cuff or an actual white pressure bag if they have them, and then run it through your saline into your nasal cannula. Not a end-tidal cannula, please. Those are more expensive, not used for that. All right, regular nasal cannula, and flush the eyes out. It does make a mess, so towel underneath them to soak up a lot of the fluid. So a foreign body will leave a small abrasion on the conjunctiva. So gentle irrigation usually will not wash out foreign bodies stuck to the cornea or lying under the eyelid. So if you spot a foreign object, you may be able to remove it with a sterile, moist, cotton-tipped applicator. And in 28-1, you can see how to do that. Basically, it's like a Q-tip almost, but with a long wooden stick. And you just put a little bit of water on the end of it and pull the eyelid down. You can kind of scoop it out, kind of make it stick to it. Right. Foreign bodies may be impaled in the eye. Like I said, I had a person that got a taser probe right through the pupil. So when he looked around, the probe moved. It was really creepy. And he wouldn't let me put a cup over it. We had to do a transfer to Maine Med out of Sanford for that. So your care involves stabilizing the object. The best thing to do with this, if it's in the eye, is put a bigger cup over it, and then apply and then tape the cup down with bandages. Over there, and then also block the other eye as well. right? Because if you only do one eye, you can't just move one eye and not the other. So again, like Jason's doing with his fingers there, right? They both move. So you got to literally put an eye patch in one and then cup the other, or then they stop looking around. Stop the burn and prevent any kind of further damage like chemical burns. Flush the eye out. And then again, we don't carry enough with this saline flush. You really need to actually flush these eyes with lots of water, right? As long as it's not water reactive. All right, as you can see here, right? If you're flushing, put it in a catch basin, right? Because this does make a big mess. So as you can see here, the affected eye here is aiming downward, right? So she's not going to flush chemicals into the good eye. Right? Chemical burns, remember, you may have to force the eyelid open. So you take 2 fingers and open it up. It's going to be uncomfortable for them, but again, we have to do it. Okay, put force into it, open the eyes. If the burn was caused by an alkali or a strong acid, irrigate it continuously for at least 20 minutes. We do not carry enough saline on the ambulance to irrigate for a full 20 minutes rapidly, right? They need water from like a sink or something like that to wash it out. Right, so thermal burns. During a fire, the eyelids will close protected from heat. Eyelids are frequently burned and require specialized care. So cover both eyes with sterile moistened sterile saline dressings and then transport. Light burns like infrared rays, eclipse lights, and laser beams all can cause significant damage to the sensory cells of the eye. So retinal injuries caused by exposure to extremely bright light are generally not painful, but result in permanent damage though. Superficial burns can also be a result from ultraviolet rays, arc welding light produced, prolonged exposure to a sun lamp, or reflective light from bright like snow-covered areas. Have you ever had the eye drops that dilate your pupils? Yeah, you literally have to wear like sunglasses outside because it hurts your eyes so bad. I had that done once. Oh, it was miserable. Right, it may not be painful at first, but 3 to 5 hours later, you start feeling some pain. So cover each eye with sterile, moist pads and eye shields. I don't know of any ambulance that carries eye shields, honestly. Lacerations require very careful repair to restore appearance and function. So if there's a laceration to the globe itself, apply no pressure. Please do not push on the eyeballs, okay? All right, just cover over them with a soft dressing. Then protect it with a metal eye shield, a cup, or a sterile dressing. Do not attempt, if the rare occasion the eyeball may be displaced from a socket, so an extruded eyeball, please do not take the eyeball and kind of like pull on it and don't push it back in, right? Don't attempt to reposition it. Cover the eye and stabilize with a moist sterile dressing. Cover both eyes, prevent further damage. Have the patient lie supine to prevent loss of fluid from the eye itself, okay? And the old,
Kevin, when you say we talked about it earlier with the abdominal wounds, and then here again with this wound as well. Whenever you say a moist sterile dressing, are you talking like we take a piece of gauze that you have and then you wet it with like
sterile water? Yeah.
Saline. So a bag of an IV bag. You don't have actual like wetted
bottles.
You have bottles too.
Yeah, you should be. Most ambulances carry like 1,000 or 2,000 mLs of bottled saline.
Sterile saline. Yeah.
And they also carry like 2,000 mLs of sterile water.
And that's what you would use to do this.
Remember that sodium chloride has salt and it can dry things. Sterile water does not. Right? Because salt dries things up. Right. So the other thing here is my God, I can't think today. Blunt trauma obscures all parts of the iris. The hyphema, the orbital fracture is a fracture of the bones that the eye that form the eye floor and support the globe. That's the orbit around it. Retinal detachment is often seen in sports as well. So eye injuries following head injuries. So signs and symptoms of a possible head injury: one pupil larger than the other. Patients that do not have anoscoria. Eyes moving. Not moving together or pointing in different directions. Failure of the eyes to follow movement of your fingers. That's your accommodation. Bleeding under the conjunctiva, protrusion or bulging of one eye So management for this would be is keeping the eyelids closed and cover the lids with a moist, sterile, moist gauze and hold them with closed with clear tape. Blast injuries. Signs and symptoms of blast injuries range from severe pain and loss of vision to foreign bodies within the globe itself. So management with injuries on the eye depends on the severity of the injury. Again, you have to do an assessment and see how you're going to treat it. Contact lenses and artificial eyes. In general, do not attempt to remove contact lenses except for chemical burns. To remove a hard contact lens, use a small suction cup moistened with the end of the sterile saline. We don't carry these on the ambulance. At least I know Services Eyeworks never did. To remove a soft contact lens, place 1 or 2 drops of saline in the eye. Gently pinch the lens between your gloved thumb and index finger and lift to the surface of the eye. Place the lens in a container in a sterile saline solution. So a saline flush is perfectly fine for that. Advise the hospital staff that the patient is wearing contact lenses and care for an artificial eye as you would a normal one. As you can see here. In these photos. I have never seen one of these on an ambulance before. Ever. In almost 25 years. I've never seen a suction cup for a glass lens. All right, epitaxis, nosebleeds are a very common problem. One of the most common causes is digital trauma, picking of your nose. Categorized in anterior and posterior epitaxis, anterior nosebleeds usually originate from the area of the septum and bleed fairly slow. Posterior nosebleeds are usually more severe and often cause blood to drain into the patient's throat. All right, one cause of this would be, what is this?
Hypertension.
Hypertension. All right, patients that have significant nosebleeds, check their blood pressure, because my guess is they're probably going to be like 220 over like 140. Right, they'll have very hypertensive patients. Unless they're digging for gold, and then that could cause it too. Or injuries, or just dry. Well, we got pictures. Is it picture time, Fred?
His eyes all bloodshot.
Yep, interesting. Some vessels broken there. All right, so assess the nose structures for injuries as well, right? So as you can see on the picture here, there's 3 different canals. There's superior, inferior, and middle. Those are called turbinates. Inside of these here, they have little hair follicles inside as well that help filter the air coming in, right? So the nose has 2 chambers divided into the septum. Each chamber is composed of layers of bone called turbinates. 3 turbinates coming in, right? Here's your septum here of the nose. These are your sinuses. There's a sinus here. There's a sinus here. Oh, what just happened? Go back. There as well. All right. The patients with severe nasal injuries may also have cervical injuries as well. Cerebral spinal fluid, CSF, may escape down through the nose following a fracture at the base of the skull. In the skull, right, we have our subdural, epidural, and you have your subarachnoid or your arachnoid. Inside the subarachnoid is where your CSF is stored, right? So that if there's a fracture somewhere there, it can start leaking out. The ear is divided into 3 parts: external, middle, and inner ear. Here's a picture of the ear, right? This is the pinna. This is the external auditory canal coming in, right? Your tympanic membrane or your eardrum is located here. This is called the hammer, right? The anvil is here, and the stirrup is here. This is the cochlea. You ever seen a patient that had cochlear implants before? Okay,
Yeah.
that's where it's going into in here, the cochlea. Now, this thing right here, right, is called the eustachian tube. Right? The eustachian tube is where air, when you have to pop your ears, right? That's air that goes directly into your airway. It's an open canal that goes down called the eustachian tube. The outer ear, middle, and inner. You can kind of see drawing a line straight down. All right. So the stirrup, anvil, and hammer would be part of your middle ear, the cochlea, and along with the eustachian tube or your inner ear. Then your outer ear, you have your tympanic membrane going out. This is where like all your earwax is stored in here, right? Perfect. So ears are often injured, but they don't usually bleed very much. So in case of an ear avulsion, wrap the avulsed part in the moist sterile dressing and put it in a plastic bag. Tympanic membrane rupture, patient reports severe ear pain, difficulty hearing or ringing in the affected ear itself. All right, so you have that tympanic membrane or the eardrum fracture. Rupture. Tympanic may be also caused by insertion of objects too far in the ear, like when using Q-tips to clean your ear out. When you push too far, you can rupture that tympanic membrane. So putting foreign bodies in. If there's clear fluid coming from the ear, that may also indicate a skull fracture. That clear fluid is what again?
Yeah.
Spinal fluid.
CFS.
Cerebral spinal fluid, yep. And how do we know if it's cerebral spinal fluid? What can we do? What kind of what kind of test is that called?
Halo, the
Halo.
halo.
Halo. Perfect. Good job. Typical result from blunt trauma, blunt impact, or facial fractures. Assume that direct blow to the mouth or nose has caused facial fractures, right? Because facial bones can break pretty easily. Signs and symptoms would be mouth, bleeding in the mouth, inability to swallow or talk, absent or loose teeth, and or movable bone fragments. So when you're doing your facial assessment, you have to look in the mouth and look for missing teeth, right? Fractured teeth, not just ones that fell out from rot. All right. Facial fractures alone are not acute emergencies unless there is serious bleeding. All right. In addition to external hemorrhage, there is a danger of blood clots in the upper airway causing an obstruction. Plastic surgeons can repair damage to the face and mouth if injuries are treated within 7 to 10 days. So remove and save any loose teeth and bone fragments because it's often possible to replant them. If you have a tooth that came out, you need to put it in something with calcium. So milk is the best thing to put it in. All right. So you might have to get some milk so that we carry that on the ambulance. But if you have milk or if you're at a patient's home and they lost a tooth, ask them for a glass of milk and stick the tooth inside of it. All right. So dental injuries can be traumatic to patients. It's amazing how many patients go to the ER because they have tooth pain. It's crazy. So they can't go because they won't go to a dentist. So bleeding will occur whenever a tooth is violently displaced from its socket. Direct pressure to stop the bleeding, perform suction if needed, and cracked or loose teeth are also possible airway obstructions as well. So again, if the tooth actually fell out, it can be put back in. I've seen physicians actually shove it back into the socket before. Right, so save it. Right. Handling it by the crown rather than the root. Okay, we don't want to hurt the root at all. Place the tooth in a storage solution. Cold milk or sterile saline is fine too, but cold milk is the best because it's full of calcium. You may encounter an object impaled in the patient's cheek. If you're unable to control bleeding, take it out. Consider removing it. Provide direct pressure. The amount of bandaging should not include the mouth. So because it's bleeding doesn't mean you shove as much bandaging as you can in the patient's airway. Doesn't do any good for you. Right. The neck contains many structures vulnerable to injury by blunt trauma. Upper airway, esophagus, carotid arteries, jugular veins, thyroid cartilage are the Adam's apple, cricoid cartilage, upper part of the trachea. So blunt injuries or any crush injury of the upper part of the neck is likely to involve the larynx or trachea. This can lead to a loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction, and a leakage of air into the soft tissues of the neck. right? We don't want that either, right? The soft tissues of the neck can start causing like a subcutaneous emphysema, right? So if you had the patient's head here, and let's say this is his neck, right? And then his body is here, right? And then arms come out this way. This is a horrible photo again, as usual, right? You're going to leak air into the top of the chest in this area right here. I'm coloring in red. And as you're palpating it, it's going to feel like Rice Krispies underneath your hands, your fingers. That's subcutaneous emphysema, right? That could also, again, go into a pneumothorax. You'll start feeling it on one or both sides, all right? And then we talked about, I saw one of your questions before, a pneumomediastinum. You guys heard of that before? All right, the mediastinum is in the center of the chest here. What will happen is air will then go around it, causing a pneumomediastinum filled with air. Fatal, very fatal. All right, subcutaneous emphysema is characteristic as crackling sensation produced by the presence of air, the Rice Krispies feeling. All right, so complete airway obstruction can develop rapidly. So consider ALS support and consider spinal motion restriction. All right, so penetrating injuries can cause profuse bleeding from laceration of the great vessels of the neck. Injuries to the carotid and jugular veins can cause the body to bleed out very, very fast, very quickly. All right, injuries to large vessels may also allow air to enter the circulatory system, which can lead to an air embolus and cardiac arrest. Direct pressure will control most of the bleeding that's there, though. Laryngeal injuries, laryngeal, or blunt force trauma to the larynx can occur when unrestrained driver strikes a steering wheel, snowmobile rider or off-road biker strikes a clothesline or a fixed wire. The larynx becomes crushed against the cervical spine, resulting in soft tissue injury, fractures, and a separation of the fascia. So strangulation injuries can also be found either intentional or unintentional hangings. And anytime there is a suspected injury to the larynx, suspect a possible cervical spine injury as well. Right? It takes a lot of force to break one, to fracture your larynx. Almost there. Penetrating or impaled objects in the larynx should not be removed unless they interfere with cardiopulmonary resuscitation. So stabilize objects if they are obstructing the airway. All right. 2 more to go. So significant injuries to the larynx pose an immediate risk of airway compromise. So signs of symptoms of larynx injuries include respiratory distress, hoarseness, pain, difficulty swallowing, cyanosis, pale skin, sputum in the wound, subcutaneous emphysema, bruising on the neck, hematoma, and bleeding. So things to look for. And to finish up, signs and symptoms of larynx include distress, hoarseness, swallowing, cyanosis, pale skin, sputum in the wound, again, bruising, hematoma, bleeding. So management is going to be providing oxygen and ventilation, cervical collar, but avoid using the rigid collars. We don't carry soft collars, so what are we going to use?
Towel.
Towel.
Yeah. Towel, bath blanket, something that's not rigid, but will keep the neck still. Perfect. All right, so let's finish
Horse
up with some
collar.
review questions. What was that?
A horse collar. Isn't that what he called it?
Oh, that's what Morgan and they were showing
Yep.
us in class.
Yeah, there's another name for a horse collar. Which of the following statements regarding the Adam's apple is false?
D.
I think it's A.
A.
A, it is. I promise
Oh,
you
it's
it is. There you go.
false.
A.
Yay.
The globe of the eye is also called.
I'm gonna be
The globe is also called the orbit. B.
Eyeball.
Oh no. Yeah, you're right.
The
D.
globe of the eye.
It's called the eyeball. Yeah.
It is. I just don't know what just happened. There we go. When a person is looking at an object up close, the pupil should do what?
Strap. B.
I heard B.
Hmm.
Yeah, B it is. Number 4, when caring for a chemical burn to the eye, the EMT should do what?
A.
A.
I was gonna say A.
Yeah, A. All right, number 5, which of the following signs is least indicative of a head injury? Least indicative.
I'm gonna say
B.
B.
Yep.
Yeah.
B it is. Number 6, the purpose of the eustachian tube is to do what?
C.
And that was
C.
not in the presentation, but I did talk
C.
about it.
C.
Charlie.
C. My goodness. Yes. What did I just do again? I need to sleep, I think. All right.
I was gonna say that or speech therapy.
I can't speak today. I need a stroke assessment. All right. So when caring for a patient, when caring for a patient with facial trauma, the EMT should be most concerned with
B.
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 Airway.
B.
Always airway.
B.
B it is.
It's always the airway.
Oh, it's always lupus. All right.
On house it is.
Right?
The presence of subcutaneous emphysema following trauma to the face and throat is most suggestive of what?
C.
Tracheal.
Yeah, C it
C.
is. Tracheal. A 21-year-old male has a large laceration to his neck. When you assess him, you note that bright red blood is spurting from the left side of his neck. Oh boy. You should
Yeah.
immediately do what? Please don't put a tourniquet on.
Run away.
A.
I would
Put your
say
glove hand over the wound.
A. Yeah.
C.
Well,
C.
I like C.
C.
C isn't
Okay,
Charlie.
stop that bleed quickly. All right, number 10. Which of the following mechanisms of injury would most likely cause a crushing injury of the larynx and or trachea?
A.
A.
Lots of A's. All right. Off really quick.